I do agree with Dr. Sinkala that in early cirrhosis, if you've successfully suppressed the inflammation associated with hepatitis B, you do get a regression in fibrosis, and that is probably the case with this patient. So those were the comments really. So in a place with finite resources, probably a fibroscan is not indicated once you commence treatment, because it either stays the same or gets better.
Thank you so much. That makes a lot of sense and is very easy to follow. We want to thank, really, we have a panel of experts that's growing, and these are people that have done a lot of work in liver disease. So we appreciate, I have seen some questions on hepatitis C, but in the interest of time, and I know hepatitis is quite a complex topic, just to avoid information overload, we'll leave that for another session. As I mentioned, we have 12 more sessions coming up. Some of them will be had actually this December. We're going to have 3 sessions on this hepatitis B, and then we'll have some of them taking up Thursday slots at 12 hours, and we'll send out the invite. Dr. Vinikoor, there's a question from Dr. Bwale. I think we are having a side chat. Do you want to loop us into that conversation?
Yeah, your questions are so wonderful. I wish we could spend more time together. But yeah, I think probably I provoked more questions than answers and gave you answers today. But there have been a couple questions in the chat about resistance. And the reason we emphasize on tenofovir is that tenofovir is like a magical drug in HBV because the virus doesn't get resistant. It's really something else. So lamivudine, which is an older drug, can also help with hepatitis, but resistance is a problem. That's why, as I said, if you put a child on lamivudine, once they reach age where they can go on to TDF or they can go on to TAF, we switch them over because tenofovir is a very potent treatment and it's also prevention for HBV. So that was the point I think Dr. Bwale wrote in the box. Thank you very much.
You know what, hepatitis B team, you have done so well to allow a second round of polls to see how much people have understood from this whole conversation. Dr. Mbiza, please pick it up.
Okay. So which groups living with chronic hepatitis B are at increased risk of developing a complication like cirrhosis or cancer of the liver? Let's see if learning has taken place.
We appreciate everybody that's voting, but because this is the second round, we will end the poll now and share the voting and allow just a synopsis from one of the experts. Dr. Vinikoor?
Hey. Yes, great. We've increased. This is wonderful. 91% of you got this correct. People with HIV are a high-risk group when they have HBV. So we really put a lot of emphasis on co-infection in Zambia. And so just so you know, this is one of those very rare medical situations where by giving ARVs, you're killing 2 birds with 1 stone. So people with HIV and HBV, they benefit so much from the ARVs you're giving them. Next.
Thank you very much for that, Dr. Vinikoor. So it's people that are co-infected. You allow the second poll. That's why, okay. So you have a 22-year-old student that presents with jaundice and fever, a background history of having had unprotected sex a month ago. When you examine her, she's not bleeding or cirrhotic or confused. And when you get her blood work back, she doesn't have HIV, but her hepatitis B surface antigen is positive, and her LT is 1,120 international units per liter. What in this case suggests that she has acute hepatitis B monoinfection. We'll allow a
Very
few minutes.
good. I think this is 99%. Dr. Foloshi, I think I should become the lecturer of the year. My students have 99%. Great job, everyone. So I think you've now picked up the picture of acute hepatitis B. So I promise you that most of you, when you see hepatitis B, you won't see such a high ALT, but when you do, you should know it's acute. And then the goodness is that this acute hepatitis B is usually a sign that the body's immune system is going to fight off that infection. And we rarely give treatment, and usually we just monitor clinically. Over.
Okay, thank you so much, Dr. Vinikoor. For sure, the hepatitis B team should give themselves a pat on the back. Yes, let's go ahead and vote on this one where you have somebody that has hepatitis B, surface antigen positive, and then you do serial monitoring of their ALT. They are different sexes, and there's even a child. Remember, Dr. Vinikoor reminded us it should be persistently and consecutively raised, so they should follow each other. So A.
Okay. Adult male, ALTs raised 32, then 18, then 45. Female adult, ALT raised from 15, then 14, then 19. Then a child, ALT raised from 28, then 25. Then we have a female adult, ALT raised from 15, 22, and then 27. Okay, so the question is, which of these hepatitis B mono infection individuals should start their antiviral therapy due to persistent elevated ALT?
So which of these? I will share the results, and I really appreciate the experts who have more sessions. So if we do not answer your questions today, it means we'll talk about it next time. I'll allow Dr. Vinikoor to talk about 4.3.
Yes, great job, everyone. So option D is someone who meets those criteria for persistent and elevated. So you see there that that woman has, even though the first ALT was normal, when she came for review again, it was 23, which is raised, and 27 is also raised. So that's the correct answer. And I want you to take away the idea that even slightly raised ALTs in these people with hepatitis B should be taken seriously, because remember, we're trying to identify those in the population of more than 500,000 who are at very high risk of cancer and cirrhosis and dying prematurely from this infection. So option D is one of those, and we would recommend treatment in option D. Thank you.
Thank you so much, Dr. Vinikoor. We have come to the end of this session. I'm pleasantly surprised that we have not overrun. We always oversubscribe for these sessions. We really, really want to thank Dr. Ma Asombang. She's a hepatitis B coordinator. She coordinates the studies there on hepatitis B at CIDAS for the case that she brought forth, because to have a complete echo, you always need a case. And that can be the very hard bit. So Dr. Ma, we applaud you and we really appreciate. And we hope in the subsequent 11 sessions, we'll continue to have these cases. So thank you so much. Dr. Sinkala, Dr. Koma, I know Dr. Kasi joined us, and all the facilities. Thank you so much. And we'll see you next Monday. Thank you. Thanks, Dr. Christopher, for conversation.